Okay, so this one's about antipsychotics. And I've talked about my medication history, how long I've been on meds, which meds I've been on, uh, and how I've, the reasons for why I've come off, because I have a long history of adverse physical reactions to antipsychotics. So when I'm talking to my care team about my medication, there's usually a sort of element of caution about we can't give you this, we can't give you that, we can't give you too much. And although we want you to keep taking your meds, we recognize that we can't just give you whatever we want to give you straight away. We've got to test it on you and do your Muse charts and all of this stuff. So yeah, I don't get on with quetiapine. I don't get on with aripiprazole. I don't get on with risperidone. Quetiapine, neuroleptic malignant syndrome. Aripiprazole, relapse, and neuroleptic malignant syndrome. Risperidone, chronic and severe anxiety. Amisulpride is the one I get on with. But that is not ideal either, because amisulpride is very prone to raising your prolactin. And when I've been on antipsychotic medications previously, I've been able to tolerate the weight gain. I've been able to tolerate the, because it's a very bizarre experience, the weight gain on antipsychotics. It's talked about a lot. You're going to gain weight. But what's not talked about so much is how difficult it is to explain to the people around you that it's not because you're overeating, right? So, I've had conversations with people after I've been on long courses of antipsychotics where they come up to me and they go, "Oh, you've gained a shit ton of weight," and I go, "That is correct. That is correct. I am now fat," and they'll say things like, "Oh, that's good living, that," and it's like, "No, dude, it's endocrine and it's metabolic, and there's fuck all I can do about it, and I eat like one sandwich a day. You got no idea." But yeah, I'm a lazy fat fuck. We'll go with that, shall we? And I like when I went back to working in inpatient after a long break, I bumped into a guy with whom I'd worked many years before. And the first thing he said to me was like, "You've gained weight." And I was like, "This is correct." And I also worked with another guy with whom I'd worked with many years earlier. And he was like, "I see you've gained weight." And I was like, "That's true. That's true." So you have to put up with that a lot, And when you have your annual physical health monitoring, you end up having very what feel like pointless conversations with the people who are doing your physical health monitoring. They're like, "Oh, your blood pressure's a bit high, and that wasn't the case a year ago, and your waist circumference has increased, and your BMI has increased, and maybe you should think about having a salad and going for a run." So so you find yourself in this situation where you're like, okay, all right. There's this real message that general medicine send when it comes to being on antipsychotics, which is like, if only you just moved more and ate less, you wouldn't be in this position. But my experience on antipsychotics and what I've read about antipsychotics is that you're fighting a losing battle, yeah. Because I don't know if anyone's ever tried going to the gym with no dopamine, no reward system, right? What is going to the gym? It's repeating activities. You go to the dumbbell rack and you curl 10 sets of 5. Yeah? You need motivation and a sense of reward to do that. Yeah? And if you're on antipsychotics, you don't have that. People would say to me, "You want to go for a walk?" I'd be like, "No, of course I don't want to go for a fucking walk." You know, the spark of life is not there. But everyone around you is hell bent on trying to get you to do things that you do not have the chemistry to do, right? So, um, and the more you read about, the various physical health consequences of long-term antipsychotic use, the less surprising it becomes that I find myself blowing up weight-wise and sitting in a chair all day staring into space, not really having very many thoughts, not really feeling positive or negative emotion, essentially just waiting for the day to end. Every day that I was on maintenance therapy after my second episode, I was just waiting for the day to end. I would wake up, I would sit in a chair, stare out the window, and wait for the evening so I could go to sleep again, because at least when I was asleep, I didn't have to tolerate this experience. And I don't know how much is said about how much effort goes into remaining compliant with antipsychotics. There's this idea that you just take a pill, and how hard can that be? It's like, well, very hard actually, because every time you take that pill, you are basically saying, I am willing to continue experiencing this lack of experience. I'm willing, I'm signing up for another day of music having no effect, video games being of no interest, exercise being of no interest, and so on. Yeah. So after 3 years of this, when they told me I was pre-diabetic, I was like, what am I going to do? And I had a very low moment. And then after that, I was like, maybe coming off is what I need. Maybe 3 years has been enough to stabilize myself after a second episode. And that wasn't my idea initially. It was a liaison psychiatrist who came and saw me when I was in the RD&E. Long story short, I took an overdose and self-presented at the ED, because after I took the overdose, I was very committed to that suicide attempt, but there was this kind of very strong image of my daughter. What was she going to do? How was she going to make sense of this? So then I kind of, took myself to the hospital. I was like, look, basically I've taken an overdose. I was there for 3 days, but liaison psychiatry came and saw me. And they said, listen, you've been stable for 3 years. Maybe you could reduce or come off. And that opened the door to a conversation with the GP. Because previously the GP was like, every time I asked, once every 6 months over that 3-year maintenance period, I was like, any chance I could, reduce the antipsychotic? I think that's part of the problem. He would say, well, the recommendation is that we need to stay on this. So because I had this kind of gift from the liaison psychiatrist in the form of his clinical opinion, I could then take that to the GP and say, listen, this isn't coming from me. This is coming from a professional. What do you think? And at that point, we were able to start exploring it. Again, we're back to people with schizophrenia reporting that they don't have any credibility. So, we started that process. He recommended a taper, reducing 50 milligrams every 8 weeks. And I said, yeah, that sounds good. But by the point that I was suggesting coming off to him, I'd already stopped about 3 weeks earlier. I was like, I can't take this anymore. I'm just going to stop taking it. And I'd already started to feel quite a bit better. So I was like, I don't know what I'm going to do. I don't really want to tell him that I've stopped cold turkey over the phone. I very much took the it's easier to ask forgiveness than permission approach. I was like, well, maybe if I tell him after I've actually been off cold turkey for 8 weeks and been fine, I'll kind of have that behind me as some sort of evidence that it at least is not a problem, right? So I actually have a call with him in about a week to tell him that I came off cold turkey about 6 weeks ago. And I've also written a letter to CMHT to let them know that that's what I've done. So I have this long and complicated physical health history with antipsychotics, which means that people are very reluctant to give them to me, but they're also, when we find one that works, when that happens, there's a sort of push for me to remain on them. And I've written a piece in Schizophrenia Bulletin about discontinuing. It was published a couple of days ago, first-person account, where I kind of go into some of the thinking behind, like, look, I understand some people, treatment-resistant, people who have ongoing symptoms when they're out in the community, even on medication, they might need depots, they might need maintenance therapy. But maintenance therapy for a broader subgroup of the population, that might be overkill. Like, there are a lot of things in my clinical history that are very protective. So maybe I could come off, and if I could come off, it's nice to come off. I listen to music for pleasure again. I play video games with enthusiasm again. I walk from where I am right now to the centre of Exeter, something I haven't done in many years, and it's not a problem. I feel clearer mentally. I feel, better emotionally. I feel positive and negative emotion. And, so I think if you can come off and it's safe and that's an option that's available to you, that's something to explore if you're struggling and you're feeling down. And, because we were very much addressing my mood problems from an antidepressant standpoint. So it was like, well, you're on an antipsychotic, you've got prolactin levels of 1200, you're getting fat and everyone's telling you that, you're no longer functioning sexually, you don't feel anything every day, so let's give you an antidepressant. And it didn't really work. So then I was like, well, maybe it's not depression. Maybe it's not about serotonin. Maybe it's about testosterone and dopamine. And, not having enough of those. So, yeah. So I've come off. And I'm keeping an eye on myself in terms of relapse risk. But my experience of antipsychotics has been that the physical side effects are very hard to tolerate. It actually takes a conscious and concerted effort to comply with the regimen. Like, taking antipsychotics is not, in my experience, a passive thing. You actually have to choose to keep doing it, even though it's very uncomfortable. And even though you're sacrificing dimensions of your experience that are really quite important for your well-being. And then in addition to that, you're surrounded by people who have no idea about what these medications do and who continue to have very high expectations of you. So they will want you to show emotion, even though you can't. They will want you to go for a walk, even though you can't. They will want you to not be fat, even though you can't. And they will spend lots of time suggesting things to you that don't work because you do not know what you're going through. You cannot, until you're blue in the face, you can say, I am on medication. I've done this with mental health professionals. The second time I went and worked in inpatient, people were like, you've gained weight. And I was like, that is true. I am on antipsychotics. And the vast majority of people there in the staff group were like, oh, I'm sure it's something else as well. I'm sure it's other things. It's like, you literally spend your entire day with people who are on these medications and also happen to be overweight. And you haven't made the connection that someone else who takes them might have gained weight. There's this kind of reluctance to accept that yes, antipsychotics are super important. Like if you're in a psychotic episode and you're delusional, you can't sit down and do CBT and make that go away. You need an antipsychotic, right? Unless you're one of the lucky ones like me who kind of may have remitted naturally in that first episode. But it's not clinically sensible to just leave people unmedicated in an attempt to try and find out who among everybody who's ill might have that experience. You know, it's sensible to give people medication. Delusions and psychosis is generally not nice. But the hardest thing about it for me is like trying to explain to other people. And there's this strong desire to be like, can I just give you one? Can I just, for a week, can I just force feed you some risperidone? And then you can tell me next Monday morning whether or not you feel like going to work, or you feel like cooking an elaborate meal, or you feel like going out and seeing friends. Because I can guarantee you, your perspective will change. But from the outside, when you're not on these medications, you can't empathize with it because you have all the chemicals that I don't have. You know, you have a functioning reward system, you know. So it's that's the biggest challenge for me. It's not necessarily taking the medication and putting up with the side effects, which are problematic, but it's the lack of social understanding about what you can and can't do as a result of being on them. I wasn't on a very high dose. I just think my body's very sensitive to antipsychotics because, you know, even when I was given risperidone in the second inpatient spell, I said to the psychiatrist, like, I'm starting to feel a lot better very quickly, and the nurses don't believe that the medication is working. You know, the nurses believe it's too soon for the medication to be having any effect, but I'm feeling an effect, and you know, I did respond to 25 milligrams of quetiapine in my first episode, so maybe I'm sort of super sensitive to antipsychotics, or I'm a super responder, or something like that. And he was like, it's possible, but, you know, some of it could be placebo, some of it could be, you know. But, yeah, it's quite a difficult place to find yourself in from a stigma and sort of lack of understanding point of view. You're surrounded by people who are like, well, you have schizophrenia, so we don't have to listen to you, and you're doing something that I don't know anything about, so I'm just going to bombard you with useless advice. You know, have a salad. I've done it. I did low carb, I did keto, I've done all of these things, still continue to gain weight. It's the effects on your metabolism and blood glucose and all of those things, hormones. The deck is really stacked against you in terms of physical health on antipsychotics. You know, there are some things you just cannot change with lifestyle. You can't, you know. So, and there's very little understanding in my experience, anecdotally, at least within the small kind of the small realm of my social experience. But when you come off and you start making, you know, you start having more energy and expressing emotion again, people seem to leave you alone. People seem to go, oh, it's good to have you back. You know, okay, yeah, I can sort of listen to you now. So, yeah, it's a very complex, I think there is a relationship between antipsychotics, side effects, and stigma. But that's been my experience. So, of course, in the future, I'll probably go back on. But if I can avoid a depot, I will. And they probably wouldn't give me a depot anyway because of this long history of having bad things happen physically. It probably wouldn't be a good idea. So I've got that going for me. But yeah, it's complicated. You really have to put the effort in to stick with it. And I don't think people get the credit for it. You know, 3 years of taking amisulpride when I felt awful was very hard to do that, you know. But yeah, that's my take on antipsychotics.